Good evening, everyone. My name is Frances Baraplo and I'm the chair of the AAPC Education Subcommittee. It's my absolute honour and privilege to introduce our speaker tonight for the webinar. I'd like to introduce Professor Parker Magin. Professor Magin has decades of experience in not only teaching, but also research in the training of Australian general practitioners. Tonight, Parker has a presentation using GP registrars contemporaneously recorded in consultation data for education and research. If anyone's interested in knowing more about the Education Subcommittee for AAPC, please reach out. I'll put my email in the chat. We'd love to hear from you. The AAPC Education Subcommittee consists of representatives from not only GP practice, but a range of disciplines. And we're looking at contemporarily what's happening in training for all our disciplines across Australia. I'd now like to hand over to Professor Magin. Thank you.
Thank you, Frances. And as Frances says, we're going to talk tonight about the recent project, which is a long-running project looking at the in-consultation clinical and educational experiences of GP registrars in Australia. I'd first just like to acknowledge the traditional owners of the lands on which we're meeting. I'm here in Awabakal country in Newcastle, and also like to pay respects to elders past, present and emerging. So the context of recent as a project that's been conducted in Australian GP training. The Australian model of GP training is an apprenticeship-like model where registrars work usually in private practice under the care of an experienced GP supervisor. So that's generally in small healthcare facilities, certainly much smaller than the hospitals in which many subspecialists train. And they're also geographically dispersed. And that tends to create sometimes some level of isolation for trainees. And the other aspect is that there's a high level of trainee clinical autonomy. So when I've had colleagues from the UK and Canada out working here in Australia, they've sometimes expressed a bit of surprise at just how much autonomy our registrars have in their clinical practice. And in that situation of the geographically dispersed small multiple facilities and that high level of trainee clinical autonomy, there's a real role for epidemiology in documenting registrars' experiences and behaviours, and to help us understand what registrars are seeing, what they're doing, so that can inform the educational program we produce for them. And the context here is, again, that before recent, we really had no idea what registrars did. We had no idea what was happening behind that consultation door. A Dutch GP PhD student around the same time we started recent did a small doctoral study and aimed at what he described as opening the black box of trainees' clinical experience. And that was very much what we were wanting to do with recent. And there were some models there. For established GPs, there in a number of countries, there were studies that again did look at that consultation content. What GPs were seeing, and what they were doing. So when we were planning recent, we looked at those, and there's quite a lot of overlap in the material they were collecting, and much of that we felt was also relevant to registrars' practice. So we looked especially at the ambulatory medical care study in the US and the beach study in Australia, and as much as possible, when it was appropriate to our registrars' experience, we used items that were equivalent to those in BISH so that we could compare with established GPs. And we also had some things beyond these studies of established GPs because we wanted to look at some of the educational content of registrars' consultations. So our overall aim was to document the in-consultation clinical and educational experience and the clinical actions of GP registrars. So we conducted a pilot in 2009 and then the project proper commenced in 2010. It's been going continuously since then, although there have been some shifts and iterations. But those figures we have there of 5,300 plus registrars, 750,000 consultations and 1,400 practices. They're from a little while ago. I would suspect we're probably up somewhere near 6,000 registrars having participated so far. And during the 15 years of the program, there have been some major iterations. The first big shock was the change from regional training providers to regional training organisations, which happened in 2015-16, and the change from RTOs to college-led training in 2022-23. And for recent, that meant transferring across to the RACGP, and we no longer had ACRM practices participating. The other big change was just before the pandemic in 2020, we changed to an online electronic data collection system rather than the old paper-based, the paper pads. And if we look at GP training in Australia, in the RTP era, we were operating in North Queensland, the Hunter Manning Central Coast region of New South Wales, Melbourne, Tasmania, and half of South Australia. And then in the RTO era, it was the whole of New South Wales, ACT, and Tasmania, plus the eastern half of Victoria. And now that we've transferred across to the RACGP, we're rolling out recent to the rest of Australia. So this year we've gone to South Australia and South East Queensland, and the rest of Australia, WA, the Northern Territory, and Northwestern Queensland will bring on board next year. So the important concept is recent is comprised of both education and research elements. And the education really is first and foremost, but the education and research functions are interrelated and they're synergistic. It all works together, and that's what we'll come to as we work through the talk tonight. So that's the bigger picture. So, but where do we collect data? Who do we collect it from? And what are the arrangements? So registrars in Australian training can do up to 4 6-month training terms in general practice terms. And 3 of those, they have to do at least 3 are mandatory. And so we collect data in each of those 3 mandatory terms. We collect data from full-time and part-time registrars, and we collect only office-based consultations. For logistic reasons, we don't collect data in aged care facilities or home visits, and we don't collect data in Defence Force facilities, and at this point not in AMSs, although we are working towards being able to do that. The other thing is we don't collect data from intra-practice clinics, so that's flu needle clinics, immunisation clinics, etc. While that would be of considerable interest from a research point of view to include those, it interferes with the educational intent if a registrar their data is packaged back to them as a whole lot of 5-minute immunisation consultations. And we do 2 data collection rounds per year, 1 in each of semester 1 and semester 2. So what are the implications of us collecting that data? So firstly, recent's an integral part of the registrar's education training, and it's completed by all registrars. So that's for educational purposes. If we're to use the data for research purposes, that requires specific informed consent by the individual registrar. So each of their 3 terms, registrars complete a short questionnaire And then they have they record information from 60 consecutive consultations on individual case report forms, and 60 patients is approximately 1 week's work for a full-time registrar. And there are implications for time management in the Registrar's Clinic. Recording information takes on average around 2 minutes per patient. And that doesn't seem much, but that will add up over a session or a day. And the kind of data we collect, I think these are one of the old hard copy forms, and probably this is the easier way to appreciate. We collect quite a lot of data, a lot of different variables are collected, but most of those won't be completed in any one a single consultation. In the old days, when these forms came back to us, it was pretty apparent that most of the form was blank. It was mostly white, and that's because most of those things there, a lot of those things there in any one consultation won't be relevant, won't have happened during the consultation. With the online forms, they now look like this, and probably the central piece of information in these forms is down here, the problem diagnosis. The registrars have spaces for up to 4 problems diagnoses, and that's where they record, as best they can express it, what the diagnosis was that they were dealing with, and if they can't apply a diagnosis, a problem formulation. That they may not be confident enough to say that the diagnosis is pneumonia. The best they may be able to say is shortness of breath, but their best description is what we record. Then, as you can see there are a whole lot of other classifications of data that the registrars record if it's relevant to that consultation. And then the workflow with Recent, you can see there in step 1, the electronic portal is opened up for the individual registrar, and they can then go in and complete their questionnaire and start completing their consultation forms. After they've collected 60, they press a button and submit the data, and then it's our job to code that data, to code their problem formulations or their diagnoses to ICPC2 plus coding system, and we quite a bit of data cleaning and data checking, and then we produce a reflective report, and we'll talk more about that reflective report shortly. But that report is then sent out to the registrar, their supervisor, and their medical educator. And in the old hard copy system, we used to undertake to do that in 3 weeks. With the electronic data collection, we aim to do that within 2 weeks, as it's really important with reflection on practice to get that reflective material back to the registrar as soon as possible to aid that reflection. And beyond that, as we go up to step 9 there, the data then undergoes further work and both for educational purposes within the training program and also for research purposes, analyses for research purposes. So we'll talk first about the educational aspects, and as you can see there, we describe that as being at the micro level, the meso level, and the macro level to get a bit of an understanding of how we're using that data. So we'll go through each of those. And at the micro level, we produce reflective feedback also to practices once a year, once they've had enough registrar terms to make that meaningful. But the real focus is on the registrar's reflective reports. And here you can just see the front page of a registrar's report. And with the reports, they're now quite lengthy. They're 16 pages, and my colleague Simon Morgan and I when we were medical educators and were starting out first doing Recent, we felt it was important that we kept the reports really quite short, that we didn't want to overload the registrars with too much information. We felt they just wouldn't read it. But at the completion of each round, when we looked at the feedback from the registrars, no one was asking for a briefer, easier report. They were all asking for more to be included. And so over time, the reports have grown larger, and they probably are continuing to get larger bit by bit. And as you can see, you may be able to see there, but we process the registrar's data and send it back to them on a whole lot of parameters, and we compare their findings with those of the normative findings for all registrars previously and recent. And for variables that we have appropriate comparison, and that comparison is with published figures from the Beach study, we also provide a comparison with established GPs. So the registrar can compare with their registrar peers, with their established GP colleagues, and also once they've done more than one term, we have an internal comparison of the registrar of their term 1 data compared to their term 2 data, and then compared to their term 3 data. So as an example of that, here we have one of the figures from a registrar report, and as you can see on the y-axis is the percentage of consultations in which help was sought. Now this is in consultation seeking of information, advice or assistance. And the main sources, as you can see on the x-axis, we give data back on 4 sources, but the 2 major ones are their supervisor and going to electronic resources. And if we look at these, if we look at the supervisor first, the comparisons here, this is normative data for all registrars. The orange is all registrars term 1, the grey is term 2, and the charcoal is term 3. And similarly over here for electronic resources, normative data for terms 1, 2 and 3. And on the left side of each source is the index registrar, the registrar whose report this is, and the green is term 1, the dark green is term 1, the teal is term 2, and that light green grey colour is term 3. And so this is quite an atypical report, and you can see that this registrar has been calling the supervisor in really not very much in terms 1 and 2, much less than their registrar peers. But in term 3, it almost looks like there's an overcompensation, and they're calling their registrar, their supervisor in at a rate that's really way beyond that of their term 3 peers. And you'd have to wonder why that is. Were there issues in term 1 or 2 where they'd seen very simple consultations? They were perhaps seeing a whole lot of minor colds. Seems pretty unlikely, but it could happen. And term 3, it doesn't really all gel. Or could there be some kind of structural issue in the way in consultation supervision is delivered in the practice, or there's some kind of problem in the relationship between the supervisor and registrar in a practice that they did their first 2 terms in? Again, that seems unlikely because there's a similar pattern with electronic resources. So it's really hard to know. Could it be something with the registrar that they're having trouble coping with general practice, and that led to some avoidance in terms 1 and 2, and burnout and over-reliance on the supervisor in term 3. It's really impossible to know just by looking at numbers, and that's the point, that this is a reflective exercise, not a benchmarking exercise. There are no right or wrong or good or bad patterns, but when something like this, it needs to be evaluated, and first of all, critically evaluated. Are there any issues that could have produced that? And then reflection, what does it mean for the registrar and for their learning? So again, the mantra is recent's a reflective exercise, not a benchmarking exercise, as an educational tool. The other thing that another aim is that is to actually prompt learning around reflection. By that I mean reflection on practice is a professional skill. It's something that all clinicians need to develop, and GPs perhaps even more than most. But it's not innate. It's a learned skill, and our contention is that, like everything else in our apprenticeship-like model, learning this skill is best done guided and with support by an experienced clinician, their supervisor. So were we able to prompt reflection? And this is a study that was done a couple of years ago, where we had participant registrars, supervisors and MEs, and in that, close to 80% of registrars felt that reflection on their recent report helped them to reflect on their clinical practice, and also to quite a reasonable degree on their learning needs and their training needs. And what's more, 54% of registrars reported that that reflection on their report then led them to change at least some aspect of their clinical practice. So that might seem like a little bit of a glass half full, half empty sort of result. But for a long time, I've been working through education to try and change clinical practice. And believe me, it is really very difficult to change clinical practice. So I think that's quite a bit more than half full, half empty. And similarly, about half of our registrars felt that the reflecting on their report helped them with their learning approaches. Does it work as part of programmatic assessment? Again, a majority of supervisors and MEs felt that the reports helped them to better understand their registrar's clinical practice and also to understand their registrar's learning needs. So if we move from the reflective reports to what we classify as the meso level, and that's where we provide findings from recent for medical educators, and especially for their educational presentations. Excuse me. So, for instance, when I used to give presentations to registrars on acne, I would use findings from recent to contextualise the information that I was giving in those talks. So I'd be able to tell them how often registrars saw acne. So it's important you listen to this because you're going to be seeing acne, to present the demographics of the patients with acne and that they would be seeing, which were quite different to the epidemiological studies of who was affected by acne. So that influenced how they would approach things clinically. And also what registrars, what management registrars were using, and how that and how did that compare with evidence-based guidelines. So the other thing, so the way we present this for supervisors is that we produce little reports on a set of data. And we do that here. We've got, it's organised by the topics of out of practice education sessions that the MEs used to present at GP Synergy, or also we had separate ones for the other RTOs. So they're the topics, and for each one of those topics, registrars have access, MEs have access to these brief summaries of data. So the kind of things that that they have here are how often registrars see the particular condition. Now this is antenatal care. The kind of specific conditions that make up antenatal care. Some demographics of registrars and patients, and also things here like the duration of consultations. So you can see that durations for antenatal care are quite a bit longer than the mean of other consultations. And also learning goals are generated much more often for antenatal care than for other consultations. And in consultation information, those information sources are accessed quite a bit more frequently. And given that most of antenatal care is made up, as you can see, of routine checkups. That's a little bit perhaps surprising that the consultations where you might expect them to be fairly routine and fairly formulaic, but they're taking longer than the average for registrars consultations. And also registrars seem to be struggling a little bit, needing information about them and generating learning goals. So that's the kind of information that MEs would then sort of inform their presentations around antenatal care. As well as these ad hoc, if any MEs want some information around a particular topic they're teaching on, then we undertake to try and extract it and produce that for their presentation. And thirdly, we use our findings at the macro level, and that's for program planning and also production of reports for education teams around a topic that's of importance. So, for instance, with our education colleagues, we looked at what were the most common reasons that registrars generate learning goals, and we're a bit surprised to find that the most common one was hypertension. It was just something that we thought was pretty straightforward, and why would registrars be needing to generate learning goals around that? But they were, and so when we thought that through further, we thought that was probably because coming from hospitals, registrars were struggling with the whole approach to managing hypertension in general practice. And so the education teams constructed and delivered an education session around how you approach hypertension in general practice. The other thing is production of reports. So, for example, like most things, GP education was blindsided by the pandemic, and there was considerable need for the education to understand how COVID had affected what the registrars were seeing and what they were doing. And so for each of and because the pandemic was patchy and not the same everywhere, we produced separate reports for each of our RTOs, basically comparing registrars, sort of the conditions they're seeing and what they're doing, compared them, and a whole lot about those other parameters we collect, how they compared prior to and during that early phase of the pandemic. And we did that. We did that in more than one occasion. We reviewed it and did it again because it was a pretty fast-moving scenario. So that's the education aspects. We can now move on to the research. So recent's a prospective inception cohort study, and more frequently in inception cohorts, the participants will enter as patients when they develop a particular disease or condition. For us, registrars enter our inception cohort study when they become a Term 1 registrar. And as we've said, all registrars do recent as part of their educational program, but registrars can also provide consent for their data to be used for research purposes. And the large majority of registrars do consent. I suppose they're already doing it anyway, so the majority are happy to consent for using their data for research purposes. So what kind of things do we do with that data? And as you can see there, we divide it up into a number of approaches, and the one that we've done mostly, and certainly in the early years, is that mapping and exploratory analyses, that unopening the black box. But also we do some more sophisticated things, longitudinal studies, testing efficacy of education, and doing some combination analyses. So we'll go through those and discuss them. So first of all, the mapping is really descriptive of how common things are, what registrars are seeing, what they're doing. The exploratory part is usually establishing associations of those exposures or clinical actions, and sometimes those analyses will have a particular hypothesis or a particular study factor, and sometimes we're just trying to really do that mapping of the area, looking an exploratory analysis, what things are associated with our particular outcome. That's also for registrars' educational actions as well as their clinical actions, and essentially that's looking at those issues around in consultation, information seeking, or else the generation of learning goals. Also, we can look at sort of other outcomes beyond the simple clinical or educational things. So we've looked at measuring registrars' responses to uncertainty and analysing the associations, how common are particular aspects of responses to uncertainty and what are the associations of those. We've looked at a construct of low-value clinical care, an index that we've constructed, and then looked at what are the associations of that low-value, non-evidence-based, questionable practice. And also looked at things like gender concordance, patient clinician gender concordance, looking how often that happens and what are the associations. Oops. So because, this is a residency study of registrars. Registrars are the participants. So we can track longitudinally how they change during practice, during their training. And we've done that looking at their prescribing of benzodiazepines, which sadly doesn't change from term 1 to term 2 to term 3, and nor does their prescribing of antibiotics. As far as changes in pathology test ordering go, we counterintuitively found that registrars' ordering of pathology tests increases with seniority, and that was a very robust finding. Just why that may be is a more complex issue, but certainly their pathology test ordering does increase from term 1 to term 2 to term 3. And as opposed to those within registrar analyses, we do within program analyses, and this is to look at how things are changed within the body of registrars rather than individual registrars. So, for instance, there we have seen that in contrast to individual registrars, as they travel through training, overall year by year in the training program, registrars are prescribing less benzodiazepines by year, and also are prescribing less antibiotics for non-pneumonia, self-limiting respiratory tract infections, and both of those are fairly pleasing. We can also do longitudinal analyses looking at prescribing of one class of drugs compared to another, as we did with diabetes medicines. And something else a little bit more complex that we can do is we can test the efficacy of educational interventions. So typically what's happened here is we've identified particular evidence practice gaps from our observational analyses in recent, establishing that there's a case for education around that outcome, and then we've also used some of the nuance, some of the associations, etc., from those observational study analyses to help inform exactly what we'll put in those interventions, those educational interventions, and then by placing those interventions delivering those interventions in between rounds of recent data collection, we're able to assess whether the education has actually changed registrars' practice. And change, as we talked about before, changing practice is not easy. And we haven't had consistently over a number of different interventions. We haven't consistently been able to show changes in practice. We have been able to, for acute bronchitis and for test ordering by trainees, but we didn't demonstrate any decrease in prescribing opioids or increase in deprescribing of inappropriate medicines. And sometimes we can combine recent data with other data sources to be able to explore research questions. So one of these is, as I said, we had constructed an index of low-value, non-evidence-based, questionable care, and that was based on the Choosing Wisely campaign. The MPS had conducted that campaign in Australia and had produced recommendations from a whole lot of peak health bodies, and we use that as a basis for constructing an index of low-value, questionable care. And with that, we were able to demonstrate that registrars' clinical practice, what they do in practice, is robustly predictive of how they perform in the RACGP fellowship exams, which I suppose is fairly reassuring that our barrier exam, our licensure exam, does reflect what, at least the aspects we're looking at, does reflect actual clinical practice. So that's the kind of things we do with research, and then we should think about how we try and integrate the research and education. So the first straightforward thing is that the project is a vehicle for research training, and so over the course of the program, we've been able to help in research training with a number of junior researchers, especially GP academic registrars. We've had 16 registrars so far who have completed the research part of their academic post completely or partly within recent. And the undergraduates, 4 of those were GP Synergy scholarships, research scholarships, and 1 was a medical student who did an intercalated research degree within his undergraduate medicine program. So we have a framework that we're aware of all the time for how we can translate what we're finding back into our educational programs, our educational practice. So we sit over here in the research team, and we engage with external collaborators, and they're often GP academics, as I've talked about, research higher degree students and academic registrars, and also medical educators, sometimes supervisors when they come to work with us, but especially medical educators. And it's these 2 groups here that are really important to us, the registrars and the medical educators, because they bring to us research ideas that are grounded in their, in the training program, that are relevant to registrars, trainers, and medical educators. And once we can construct some researchable questions, we can use observational studies, especially recent, to try and answer those questions. And the great thing about working in the GP training program is that translation loop is very short. We work closely with our educational colleagues, and we've given some examples there earlier, where when we find we have findings of note, we can work with our education colleagues to integrate them back into the education program. And that's they may be findings that are not, headline research findings, but they may be more modest, but they still may be important. And research findings, we don't have to wait to publish those. We can go and talk to if we think something's of importance, we can talk to our education colleagues and say, this is what we've found, and we don't have to wait for that whole program of publishing it and then sending the publication around, we can do it far more directly. And as I spoke about also, we can then use our findings here to identify evidence practice gaps and then construct the educational interventions and then use the non-equivalent control group design. We can't do RCTs because it's not really acceptable to education programs to be randomising the education of their registrars, but we can introduce it in those educational units, in the previously it was RTPs or RTOs who were interested in it, and then compare it because we have we measure a whole lot of independent variables. We can use that to establish the efficacy of the intervention. And so that all feeds back into the education program. And also the findings feedback, obviously, as research does, to more researchable questions. So for instance, in the very early days of recent, we had an academic registrar who was interested in antibiotic stewardship and did some studies there. And so those findings were then went off in these directions, but also they fed back more questions. And so we've had a program of looking at registrars prescribing of antibiotics, their antibiotic stewardship. Another example is having found some quite important educational findings around registrars seeing older patients. So older patient care is really important in GP training. There's an awful lot of chronic disease in general practice and a whole lot of multimorbidity. And the multimorbidity especially may not be very well, the experience in hospital may not prepare registrars very well for managing multimorbidity as the key person in the patient's healthcare. So the first thing is we found that registrars see older patients much less frequently than do established GPs. But not only do they see older patients less frequently, we had good evidence in the associations that we found in our multivariable analyses that registrars not only when they do see older patients, they often don't engage with the management. They really do seem to put on band-aids and send the patients back to their usual GPs, and that's a real loss of learning potential. So after those findings, we conducted workshops at a whole lot of conferences with medical educators and especially with supervisors, where we brainstormed ways that the supervisors might make structural changes in their practices or their workflow in the practices so that registrars were able to get more older patient care. And hopefully they took that back to their practices. And certainly in Tasmania, after those findings from recent, they gelled with the experience of a whole group of supervisors in Tasmania who came to our Tasmanian colleagues with their concerns around this and said, we want to find out what are the various ways that we might deal with this problem. And so so they basically collaborated with the education teams and with some of our research team to do a qualitative study just on that topic. Oops. And that's the paper, a qualitative study. So again, looking at how this all fits in, as a result of previous research we've done, we know that registrars mock exams, their practice exams, exams that are done early in training to assess where they're going. From our previous research, we know that they're predictive of college examination performance, and those exams then have those tests, quizzes, exams have considerable training implications or benefits. But the sceptical among us might say, well, that's just because people are good at doing quizzes and low-stakes exams are good at doing high-stakes exams. So then we've done further study where we constructed a measure of registrars' performance in and observed performance in clinical teaching visits, and we found that that was robustly predictive of exam performance. Again, the even more sceptical people might say, well, there's a Hawthorne effect there. People, when they're observed by an ECTV visitor, they're not going to do those low-value things that they might do out of convenience or patient pressure or peer pressure or whatever in real life. But with recent, we have data on what actually happens during consultations. And as I said, we constructed that index of low-value care and found that that was robustly predictive of fellowship examination performance. And we've also looked at comparing that index with our measure of performance in CTVs. That's a more nuanced, complex relationship, but I think we're pretty confident that the findings we have there support the contention that this observed performance does pretty well reflect what happens in real life. So we can think about some of the strengths and limitations of the recent. And there you can see we have a large number of variables. Important that's contemporaneously recorded. We have a high response rate and a large sample size. The big thing is the data is collected specifically for the purpose of recent, and we have a short focus period of data collection. So it's not trying to get clinicians to 100% of the time be really careful about how they record their data, because that data is going to be sucked out of their EMRs. We have this focused data collection period where hopefully the reliability of the data is greater for that. And the other thing we have that isn't available in extracted from routinely collected data is that our action variables, what the registrar prescribes or where they refer, their imaging, their pathology, in our data collection, they're directly linked to the problem of diagnosis that prompted the action. So again, that's been really useful in exploring our data. There are limitations though. So recent's very much a snapshot of a single consultation. So we don't have patients' medicines regimens. We don't know their past histories. And we don't know what happens at follow-up consultations. We know that they organise a follow-up, but we don't know what happens. And we don't know the results, obviously, of tests ordered. And also some of the context and nuance around the diagnosis problems lacking. So, for instance, we don't have an indication of how severe the condition is, just what condition it is. So a practical illustration of that perhaps is we've done a lot, as I said, we've done quite a lot of work with antibiotics in respiratory tract infections. And when we're looking at prescribing of antibiotics for sore throat, we don't know some of the context around that. So we don't know the severity, or we don't know if a registrar is using Centaur guidelines, for instance, whether we don't know the particular components of that. So that is something of a limitation. Again, we don't have home visits or aged care visits recorded, so our data is only on office-based consultations. And as I said earlier, we don't include consultations in specialty clinics, especially intra-practice clinics. And that's a little bit of a limitation sometimes for research functions. Thank you very much, and I'll just see if there are any questions. Okay, thank you.